if we're wrong? What if that patient called us for flu-like symptoms? It's actually the flu, and we say, hey, this looks, walks, talks like substance abuse disorder. They have a history. They can't tell the difference. They don't know. We give them bupe.
Yeah, so bupe is very safe. So if you gave bupe to someone who didn't have opioid withdrawal,
Yeah.
it's just going to provide some extra pain relief, and then nothing else is going to happen to them. The thing is in general, the patients who are in opioid withdrawal, if you talk to them in an empathetic way, and they're going to admit if they are having opioid withdrawal. Most of these patients know. I mean, it's not like they're patients with first-time opioid withdrawal are typically not interacting with healthcare. It's typically someone who's been struggling with it for a while because they're in the thralls of opioid use disorder and all that stuff. And so it's they're going to just tell you. You just
Sure.
As long as you empathize with them and show them respect, they're going to latch onto that and be pretty honest most of the time.
And what if you? What? Go ahead, John.
Because it's no difference if it's a patient who has diabetes, right? And they
Right.
call you, I think I'm in DKA, right? They're probably right.
Yeah, they know their
They're-
body.
Oh no, I don't disagree, but I wanted that messaging to
Yeah.
get out. Is the safety profile. of
It's
the
very
drug.
safe.
Yeah. What about the circumstance where the patient or the EMS provider wants to prevent a withdrawal that's not currently happening?
Yeah, so if somebody has too minor of withdrawal symptoms, i.e., their COW score is under a certain cut point, we can actually make withdrawal happen by giving patients buprenorphine. So it's called precipitated withdrawal, and it's often very rapid when it happens, and it makes people feel really, really bad. And the reason that this happens is because Suboxone binds the receptor so much stronger than opioids. If you have severe withdrawal and I give you or if you have severe withdrawal, that means the amount of opiates on the receptor are low. I give you some Suboxone, I will raise that stimulation a little bit. You feel better.
Yep.
But if you have very minor withdrawal, which means that the stimulation of the receptor is less than full, but higher than where
Higher.
Suboxone is, I will then rip off those opioids and pull you down to that partial stimulation, which make people feel really, really unwell. The interesting thing is that the treatment for precipitated withdrawal from Suboxone is more Suboxone. So you just keep on giving it in that situation, but we still don't want to make people feel that way because, one, it feels like crap, and we don't want to do that
Sure.
to patients. And then we may burn that bridge where they're like, oh my God, Suboxone made me feel horrible. I never want this.
Yep.
And I would say that most patients who have opioid use disorder really just need to be on Suboxone. Like, that is, to me, the drug of choice. Methadone is an option, but Suboxone is just way better. And so I don't want to burn that bridge and prevent them from being on Suboxone in the future.
So that COW score is super important.
Exactly, and so that's why the protocol will always, any protocol for this will have a minimum COW score, and that can vary from a COWs of 5 to 10, depending on inclusivity and how much you're going to risk opioid withdrawal in those situations. And the hard part with COWs is some of it's subjective. Like, there's some objective vital signs, but some of it is like, how do you feel? And so if a patient gives you one answer or you interpret it a different way, you could have a COWS score that you measure above the cut
Slightly
point,
skewed,
but it's
yeah.
actually slightly below, and so that's where it gets a little risky. So the closer you get to that low end of whatever the protocol allows, which for ours is 5, the higher the likelihood of precipitated withdrawal.
Yeah. So higher the number, the safer the.
Yeah, the worse they feel, but the safer it is
Yeah.
to not precipitate withdrawal.
Nice. Who shouldn't have it?
So the main person who shouldn't have it is somebody who's at high risk for precipitated withdrawal and somebody who is critically ill. Those are the two kind of people in these situations. So if you're on methadone, it becomes very hard to kind of use the COW score to prevent you from getting precipitated withdrawal. So anyone who's been on methadone for typically under 48 hours should not be getting Suboxone, no matter what their COW score is. And then anybody whose COW score is too low should not get it. The other one would be if you are altered and you can't consent to it, or you are just critically ill, like you have flash pulmonary edema because of Narcan rescue, which happens, or you're septic, like, just resuscitate that patient. Don't give them Suboxone. Let's save their life from the acute medical emergency and then plug
Sort
them
it
into
out,
Suboxone in the hospital. There's some other exclusion criteria, but those vary by protocol and are more, in my opinion, relative exclusions than true absolute exclusions.
What about somebody with a blended intoxication of alcohol and opiates or benzos and opiates, or when we start getting into the, the mixed pharmacokinetics here, where do we lie with that? Is it still safe, or is this a case where we should be phoning a friend?
Yeah, so if they are not so intoxicated that they lack capacity,
Yeah.
it just becomes hard to use the cow score when there's all these different receptors being stimulated by all these different drugs.
Sure.
And so it just makes it very difficult and increases the likelihood of precipitated withdrawal just because of the nature of I don't trust my cow score. So in our protocol, that is an exclusion, and we recommend involving med control. Now, is it safe to give Suboxone? Sure. I mean, the worst thing that's going to happen is precipitated withdrawal. But it's not gonna. You're not gonna do something else that's horrible. It's just accidentally causing precipitated withdrawal, which we worry about.
What about pregnant patients?
So our protocol excluded them but in my education, I specifically said that if you have a pregnant patient that has opioid withdrawal and you think is otherwise a candidate for Suboxone, please call med control because I'm going to absolutely recommend giving it. It was just hard to put that in the protocol because we don't have amazing data on the effects on kids or unborn children, but the way I look at it is, what's really bad for an unborn kid? If mom dies
yeah.
or has a bad outcome related to opioid use disorder. If we can get her into recovery, then her kiddo has the best chance at doing well. And there's lots of data that says that it is reasonable to give it to those patients. I just didn't put it in my protocol, and other protocols have excluded them as well for that reason. But in reality, if you call me, I will say, yes, please give it.
Anything special you had to do on the legal or regulatory front to start doing this with your departments, or is it just add another medicine to our state pharmacy license and move forward?
For our state, that was all I needed to do. And that was because I am kind of standing on the shoulders of all the other EMS physicians that have done this elsewhere before. It'd be very different if no one had ever done this before. But the first place that did this was Camden, New Jersey, and I think they did this in 2019, I want to say, is when they first started doing this. So we're all kind of following in their footsteps. And I'm glad that they did do this and gave us all this great idea because this really is going to help so many patients, and in my opinion will be standard of care in the next maybe 10 to 20 years at the most. If you're not doing it yet, everyone will be doing it in the future.
I think the Suboxone buprenorphine is quickly becoming kind of standard of
Yeah.
care.
Standard of care.
At least from EMS doing it. is what I was
EMS,
thinking.
emergency department, yeah.
Yeah. I would definitely say it's standard in the ER,
Yeah.
in my opinion.
I think our college came out for that. I think that organization's come out as buprenorphine is the standard of care.
Mm-hmm.
Anything else on this front that you want to get out there, other than our standard and very traditional resuscitation of the overdose patient? Now we've expanded this into preventing secondary injury from an additional or another overdose, and now we're taking care of the patients who could be withdrawing from opiates. Is there anything else left in the management of the opiate patient that we need to be looking at in the future?
Yeah, so one of the next things is just plugging them into ongoing care, because if you give them buprenorphine, you've bought them a couple days to do this, but we really want to plug them in if we can. And so that's kind of the biggest hurdle is treating this as a buprenorphine bridging them to ongoing care. And so we have partners in our county that will reach out to these patients and will plug them into either outpatient or more intensive inpatient recovery resources. And then a lot of these patients don't have a car or a way of getting there, and they'll actually provide a ride. And so that's
Very
the key is just plugging them in and getting them to those appointments or those stays so that they can get bridged to everything else. And that's often the biggest hurdle. And there's no one size fits all. It's really just what works for your specific community and what resources do you have. But that was actually the biggest hurdle, was trying to arrange for that in my county and kind of leaning on my partners in that space to do that. But I got lucky that a lot of that was kind of already designed for me and worked for exactly what this patient population needed.
Access to care is a huge problem, huge, whether that's transportation to get there or I can't go during normal business hours because I work during normal business hours and I need
Right.
my job so that way I can pay my bills and
Right.
Have
keep
my
my
health
rent.
care, right?
Yeah, exactly. So access is a huge issue. I'm glad you have partners that can work with you. When I got my X waiver, I was finding it hard to find referral sites for starting buprenorphine. Like I'm required by law that if I'm starting bupe, I also have to refer, or I could take them on myself, which I don't have the time to do nor an office to do. They can't just come back to the emergency department to have their follow-up bupe
What days are
appointments.
you working?
Yeah, exactly. Well, I'm sure Jordan gets this too. Like, I often get questions like, "Oh, like where are your offices at?" And I'm like, "Here, I'm an emergency medicine doctor. I don't have offices." I'm like, "I'm glad you like me, but not what I do, not my wheelhouse."
Right.
But I'm required to also refer them to services, and I ran into issues a few years ago when I went down this journey of getting certified to provide this medication that I couldn't find anyone to directly refer them to. That's changed now. I now have more options, so it's good. It's good that the access is getting to the patients that need it.
Yeah.
And they even talk about the resources. I know down our way, and John, you can probably talk about it too. They've created basically what they're calling an overdose response team. So like probably similar to what you guys are doing. We've got these resources available, but when these calls happen, we're getting these people to these patients to help them through the recovery and then through treatment and that sort of thing, just to have those resources get to those patients. So the different avenues that can all happen. So
You got to meet the patients where they are, because this is a high needs patient population that has often no other support. They may have, as a part of their addiction, may have burned all bridges with everyone else, and so they need a lot of help to get plugged in, and we have to meet them where they are and get them that help so that they can get their life turned around.
Or they may have had even bad interactions when they did ask for help from the healthcare apparatus, whether that's EMS, the hospital, their family doctor, whomever.
No, I mean, we had our guests earlier in the day sit here and say that in their sphere, they would do everything in their power not to go to the hospital to be treated by the professionals because because of the stigma and how they'd historically been treated.
I think just you guys were just mentioning stigma, but that's ultimately the most important hurdle that we kind of need to get over as healthcare, not necessarily us specifically, but us as a EMS system and healthcare, is just remembering that the words we use matter, because they're listening to us. Like when we're talking to each other, like in our fishbowl in the ER, or crew is talking when the patient is kind of sitting somewhere else, they hear us, whether we know it or not. And if we use the word like dirty or drug abuser or drug user, that implies a character flaw, but these people don't have character flaws, they have a disease, and if we treat it as a disease and we use the right words, we talk to them with respect, like, it's amazing what we can do and really truly turn a life around. If they're not ready to change, so be it. Just say that, hey, we're here for you, here's some resources, we'll come back and help you whenever you need it, and just be there for when they do have that epiphany and want that change. But if they're ready to change, just be that person to help plug them in if you can.
Well, imagine if we had like a COPD exacerbation called like a blue bloater. Oh, we got the blue bloater in the backyard, and we're not calling it, like, would be a different term that probably no one. I don't know if you guys have even heard that when you're talking about COPD. Okay. It's something in medicine we talk about that. But could you imagine if in the general population that we called someone a blue bloater, that they might get offended by that? And that's essentially
literally in my textbook.
But yeah, those are the words, like dirty, abuser, drug user, addict.
Yeah.
And we talked earlier, like, just it's a patient. Doesn't matter what medical condition they have. They just happen to have substance use disorder. They're just a patient. And then if they say recovery, abuse is a bad word, although even some of the terms that we have well established, and because we talked about it earlier about what those terms were, like even MAT they don't want us to use. Like, but that's the technical term for these programs that we have.
I didn't know that was something we weren't supposed to use.
So
to be honest,
there's a web page out there. It's called Words Matter, and they list out all of these different words. Which, since we're talking about it, might as well talk about it. Like bad words used, we shouldn't use addict, user, drug abuser, junkie, alcoholic, drunk, former addict, or reformed addict. Just a patient.
It's a patient, right? That's simple.
And they have a disease, and the disease is opioid use disorder, or alcohol use disorder, or substance use disorder. Like that, just like we often say somebody's a diabetic, but we really should say they're a person who has diabetes. Like
Yeah.
these people have conditions that they are not defined by their condition.
Right.
And there's oftentimes even things outside their control that send them into an exacerbation.
Right.
Same thing with substance use disorder.
Yep.
You could be a diabetic and you pick up a virus that you had no control over that sends you into DKA.
Yep. Yeah.
Same with COPD. You could get a virus that sends you an exacerbation. You have substance use disorder. You could get a virus. You could have something happen outside your control.
Span of control.
And now all of a sudden you're in exacerbation of
Yeah.
your substance use disorder. So
There was something you mentioned before that I wanted to kind of emphasize is when you said that a patient who was in recovery for like 8 years and you congratulated them for it, like that also makes a big difference. Like being in recovery for any period of time, 1 day, 1 week, 1 month, 10 years, like that's impressive. And even with something like tobacco, like when I ask a patient, like, do you have a history of smoking? They say, oh, I quit 10 years ago. I say, well,
That's awesome.
that's incredible. Like that was the single greatest thing you did for your health. That must have not been easy. I'm very glad that you did that. Just they probably don't hear that very often. They deserve that credit. And the same thing is true for opioid use disorder. Every day that they're in recovery is fantastic. They deserve credit for that. All we can do is imagine. If we haven't gone through it ourselves, all we can do is imagine how hard that is. And if they do relapse, we shouldn't look at that as like a horrible thing. It's just like, okay, yeah, this was a setback, but let's figure out what we got to get you back into recovery. How are we going to do that? Let's figure it out.
yeah, and I do that with all my patients. Same thing, like whether it's smoking or whatever the substance is. I go, congratulations for that. Or if they do relapse, like
It's okay.
it's okay. How long were you in recovery before? Oh, it was 4 years. I'm like, okay, well now we're at day 3. Let's work on day 4. And
Exactly.
Day 5, and let's get you back to 3, and then you can blow that one out of the water next
Right.
time.
Yeah.
You're gonna have those. That's why I just call them like exacerbations or whatever their use disorder is. And the normal progression isn't someone that identifies that they have a substance use disorder and they never relapse.
Yep. It's not a switch.
It's not a
Right.
switch.
Yep.
And we said this before. If we had a switch that we could turn off, whether it was through medications or cognitive therapy or or everyone that had a substance use disorder would do that.
Would do that. Yep.
Yeah.
Fantastic discussion as always. We appreciate you coming back, and we will catch you all next time. Thanks.